Hey everyone, welcome back to Decode Healthcare with Harshal for part 66 of our 100-part ICD-10 CM Guidelines series. If you've been following along with us, you know we've spent a ton of time down in the weeds of those chapter-specific codes. But today we are shifting gears into high-stakes territory. We all know the sheer panic of a DRG audit rejection, right? It's painful, it's incredibly costly, and honestly, it usually comes down to sequencing. So, our main mission in this explainer is mastering the exact rules for selecting your principal diagnosis. We're going to build an absolutely impenetrable defense for your inpatient claims. All right, let's just jump right into our agenda. We are officially transitioning into the strict CMS coding laws that govern inpatient admissions, which you'll find in Section 2 of the guidelines. First up, the absolute bedrock of inpatient coding, the UHDS Principal Diagnosis Law. Before we even think about looking at a single code, we have to establish one undeniable fact. The CMS guidelines strictly override any textbook examples you might have seen. The absolute law of the land is this exact Uniform Hospital Discharge Dataset, or UHDDS, definition of a principal diagnosis. Notice, it definitely doesn't say the condition the patient was admitted with. No, it explicitly says the condition established after study. That is absolutely crucial. Your entire diagnostic workup ultimately dictates what goes into that slot number 1. Meaning, your primary directive as a coder is to pinpoint the exact condition responsible for the admission, but only based on what is established after that diagnostic study is totally complete. And hey, it's not just for acute care. Whether you're coding for a long-term care facility or a psychiatric hospital, this UHDDS definition is absolute. You are always looking for the root cause that brought that patient a bed in the facility. Let's keep moving right along to interrelated and comparative diagnoses. You know as well as I do, patients rarely walk into the hospital with just one neat, tidy problem. Picture a scale balancing two massive clinical issues, let's say acute congestive heart failure on one side and acute renal failure on the other. Well, Section 2B offers some really brilliant flexibility here. When two interrelated conditions equally meet the principal criteria, either condition can legally occupy slot number 1. You actually have the power to sequence the one that best reflects the clinical focus for that stay, unless, of course, the tabular index specifically tells you otherwise.
So what happens when a doc throws an either-or at you at discharge? Imagine reading a discharge summary that says the patient's severe chest pain was either unstable angina or esophageal reflux. The physician, frankly, just isn't sure. Now, outpatient rules would tell you to just code a symptom, but inpatient rules? Completely different ballgame.
Under Section 2D, in the inpatient world, you actually must code both as if they were 100% confirmed. And just like with those interrelated conditions, you have the flexibility to sequence either diagnosis first. The logic here makes total sense. The hospital still expended massive resources to work up and rule out those serious conditions, so the facility absolutely deserves accurate DRG compensation for that level of care. Okay, let's tackle a notoriously tricky one, the canceled procedure rule. Let's put these rules to the ultimate real-world test, because this is a classic area where auditors just love to hunt for mistakes. Imagine an operating room timeline. A patient comes in for an elective total knee replacement due to severe osteoarthritis. But suddenly, out of nowhere, they spike severe uncontrolled hypertension in pre-op. It's so bad it forces the surgical team to cancel the procedure entirely. So what on earth is your principal diagnosis?
I know. It is so tempting to code the complication. I mean, the hypertension is what caused all of the drama and the cancellation, right? But wait, the law, specifically Section IFF, states the principal diagnosis still remains the underlying condition that caused the admission in the first place. The osteoarthritis is what brought them through the doors. The complication, no matter how severe, does not get to steal slot number 1.
Therefore, your osteoarthritis, that M17.11, stays firmly planted as your principal diagnosis. The hypertension, code I10, and the Z code representing the canceled procedure, Z53.09, those just get stacked right underneath as secondary diagnoses. If you put that hypertension first, you are going to fail that audit for sure. Always stick to the condition that occasioned the admission. Let's shift gears to Section 4, outpatient to inpatient conversions. This happens literally every single day in hospitals. And the sequencing rules here are highly specific. It creates a massive trap. Does the original surgical reason carry over, or does the brand new problem take precedence? When a patient converts from outpatient to inpatient, you have to play by an entirely different set of logic.
Let's break down the exact CMS logic under Section 2J. If the admission is strictly due to a surgical complication, or maybe a brand new acute illness, like they suddenly spike atrial fibrillation in the recovery room, that new issue takes the principal slot. It completely replaces the original reason for the outpatient surgery. However, if they are admitted just for continued care with no distinct complication at all, then the original reason for the surgery finally gets to be your principal diagnosis. And hey, it's a very similar story for medical observation. If a patient is admitted to an observation unit for a medical condition, let's say severe dehydration, and that condition just worsens or fails to improve, ultimately pushing them into a full inpatient status, that exact same medical condition stays as your principal diagnosis for the resulting inpatient stay. The chain of causality there remains unbroken. All right, let's wrap this up with our final takeaways. Let's quickly lock these complex coding laws down so you can apply them seamlessly and make your claims virtually bulletproof. Remember, CMS guidelines always supersede your textbooks. Always look for the condition established after study. Literally, never let a cancel procedure trick you into sequencing a complication first. And for those outpatient conversions, just stop and ask yourself, what specific event actually drove the inpatient admission order?
Take these rules right back to your coding desk and keep Section 2 highlighted right next to your keyboard. So, I leave you with this question. Are you ready to defend your next principal diagnosis against a DRG audit using that strict UHDDS definition? Keep coding accurately and make sure to join me next time on Decode Healthcare with Herschel as we continue mastering the ICD-10 CM guidelines. Catch you then.